The question is, in cases of corneal perforation, is it the last station? I'll represent my humble experience in such cases, which are very frequent in our daily practice at Upper Egypt. Daily, we face a perforated cornea. We have different causes may end in perforation. Traumatic, and this the better prognosis or the best prognosis in traumatic cases, but there are cases non-traumatic, either infection, which carries the worst prognosis, or non-infectious, as in cases of ocular surface disorders or autoimmune diseases. Such patient has a perforation due to trauma, will get a good prognosis because of the peripheral wound and very small, no tissue loss and no infection. Well, these all are good prognostic factors. But this patient has another perforation with a foreign body. The foreign body, usually the metallic foreign body is sterilized because almost it is crushed with a force, and there is some high temperature that almost it is not infected, but sometimes it can carry some infection. So it is a less prognosis than the older one. Another patient with perforation, this is called silent perforation, and this patient may not complain completely. They accidentally discovered almost this patient with peripheral corneal disorders, almost with rheumatoid or autoimmune disease. In this type of perforation, it is more aggressive because there is infiltrate starting corneal melting, and so management will be different from previous cases. And this one has a more extensive perforation, including the sclera, and also it needs anticipate major surgery. The last patient with almost loss of the cornea, complete melting of the cornea, and also has a poor prognosis. So all these patients may liable for endophthalmitis, choroidal hemorrhage, glaucoma, or optic atrophy or atrophy bulbi. To start the lines of treatment, I'll be brief for the time. Tissue adhesives, conjunctivo-tenon patch graft, amniotic membrane, corneoscleral tectonic graft, scleral patch graft, scleral tectonic graft, and last tectonic keratoplasty. These are the usual lines for treatment, but we have to choose the best choice for each case. As regards the tissue adhesives, it will be beneficial in patients with small perforation less than 3 millimeter. Better to have a concave surface. This will take the tissue adhesive and located away from the limbus, because the patient with perforation beside the limbus amenable for dislodgement of the tissue adhesive. So it's better to be central or more central, more or less. There is non-biologic, there is cyanoacrylate, or biologic like fibrin glue, according to the availability. It is sterile, non-toxic, biocompatible. Should dry the condition before use it, and it has a bacteriostatic effect and disrupts stromal melting. The small or minimal tips you will use paretic microscope under aseptic conditions, using topical or local anesthetic and non-compressing speculum because the eye is perforated. Debridement of the necrotic epithelium is crucial, and keep the bed dry. If the anterior chamber is collapsed, you have to form it before putting the tissue adhesives, and contact lens is a must. These are some examples for the perforated corneas. We'll use histoacryl. Another examples. The second item is tenon patch graft. Usually tenon is sufficient, but it's better to be with conjunctiva to supply with blood, because as you know, the cornea is poor in cell-mediated immunity. So we will add this factor in healing, the process of healing, and fibroblast activation. Large corneal perforation may be useful in these cases up to 6 millimeter, where tissue adhesive is not suitable. Also, it has the ability to produce autologous fibroblast. So this is the aim of this procedure, to add factor helping in the healing of the perforation. We have different types, either total, like this one, or partial pedicle, bipedicle flap, or bridge flaps. These some types of the conjunctivo-tenon graft or flaps. Advantage of the tenon patch, and there is no tissue rejection. It is readily available, مش محتاج ان احنا نجيبه من حته, and no heterologous antigenic sensitization for the later corneal grafting. مش هيعاكس الكورنيا بعد كده في الجرافتنج بعديها. These are some examples also. As regards the amniotic membrane for the perforation, amniotic membrane may be used as a multi-layered amniotic membrane, filling the defect with multiple pieces of amniotic membrane and then covering the entire cornea with a layer of the amniotic. Use sutures of fibrin as you will, managing defect up to 3 millimeters in size. May be temporary or permanent according to the position of the amniotic regarding epithelial side or stromal side. These are some examples of the amniotic membrane and the results as usual. Another one. The next item is a scleral patch graft. Sometimes we have no material ready except the sclera, and sclera may be autologous or allograft, which is suitable for any size of perforation, even low, large perforation. It is no tissue rejection, is readily available, and no sensitization to the grafting. And these are some examples of scleral patching. Scleral patches differ on item, the next item, scleral tectonic graft. This is another item, but scleral patch is just to put it in, above the defect to allow to help in healing. These are some examples of scleral patch. Another form or another item is corneoscleral tectonic grafts, such a patient with banana keratoplasty, and this rim may be taken from the bottom, the remaining of the graft instead of through it. And this patient had a scleral tectonic graft. In this item, you can divide the periphery of the perforation, remove necrotic tissue, and allow it to be rectangular because it's easier and more flotation and takes scleral patch and put it corners with stitches to fix it, and it will regain the integrity of the globe and the anterior chamber. The last item is therapeutic keratoplasty or tectonic. It will restore the integrity of the globe, reduce the microbial burden, and reduce the toxins and enzymes. You should use Friesinger ring. You should remove the necrotic tissue or diseased tissue 1 millimeter safety as a safety margin around the defect, and synechiae should be broken because the process of the possibility of post-operative glaucoma. These are some examples of therapeutic keratoplasty, pre and post application. Another one. This perforation, we have no button except an older one with a scar, but it can do well, like this patient. For this patient, large neglected perforated ulcer in patient, in one eye patient. After application, it needs some precautions during the surgery, but the outcome is useful. Another patient with perforation. Also, in this patient, we have to start to refine and complete it with scissors. Usually start from the healthy side and go toward the diseased side to preserve the pupil as you see. And then you can put your graft and complete your procedure. Take-home message. Although corneal perforation is considered devastating and vision-threatening complication, many options, tissue glue, amniotic membrane, conjunctival tenon, sclera, or corneal grafting may be tried. The choice depends on the site, size, and the cause of perforation. Earlier and proper decision might save vision of these patients.